trauma now. This will also include spinal cord injury. With head injuries, there are many ways to suffer head injury. So we have car accidents, we have penetrating and blunt force trauma to the head. And of course, the head is sitting on the spine. So with every head injury patients, we also assume the patient has spinal cord injury. And therefore, it's vice versa. Okay, so we assume the other one until we rule it out. So until we get MRI or CAT scan saying otherwise. Prevention first. So wear helmets. So who rides bikes or e-scooters here? Just make sure you, or if you know somebody, just make sure they wear helmets, okay? Wear your seat belts, have a designated driver if you go out, right? I mean, I don't have to tell you that, hopefully. Okay, you know already. Everybody should be following the rules, okay? So these are in place for your safety. And guns as well. So we've had a few in the last couple of years about kids shooting people, right? Isn't that terrible? I mean, such a young kid, you know, and you destroy that kid's life. It's not like they meant to shoot somebody, right? But anyway, so we talked about the primary, I mentioned the primary injury earlier. So there are two sets of injuries here when we have brain or head injury. So first is the primary injury. So this is referring to the contusions, lacerations, hematomas, fractures. All right. And I mentioned the secondary injuries, which we have up to 6. So they are the hypoxia, the hydrocephalus, the cerebral edema, the brain herniation, the increased ICP, and the bleeding, okay, the hematoma. Let's talk about the Monro-Kelly hypothesis or doctrine. First of all, this doctrine or this law applies only to a closed head injury. What does it apply only to? Okay, so this hypothesis does not apply if you have a open head injury. So this is referring to there could be a fracture, however, the fracture is not displaced. Okay, it's a closed fracture of the head. Now, the problem with the skull is it's the most rigid compartment in the body. So if you have any injury to any tissue, what will that tissue do normally if it's injured? It's going to swell. There's going to be edema. Now, imagine edema and swelling inside a rigid compartment. What's going to happen? It's going to be like compartment syndrome, correct? So, and no different from compartment syndrome in the limb or in the torso. So therefore, if these are the only 3 components in there, so I kind of explained this last week. So if any, right here's the explanation. If volume, again, this only applies in a closed head injury, okay? This hypothesis goes out the door once you have an open head injury. So this will mean that if there's an increase in volume in one component, any of these, these are the 3 components inside your skull. If volume increases in any one, then volume in another compartment must be displaced, correct? So I gave you the example of the water, right? Glass of water, which is already full. If you add one more drop, what will happen? Something will be displaced. What was displaced? Was it the drop that I just added? No, something else. So same example here, same idea. So if let's say the brain swells, so brain makes up about 80% of the components in the skull. So if it increases by 10%, you have to displace 10% equal volume. So where will you get that 10%? Now the total blood volume and total CSF volume are each 10% of the skull content. So can you displace the whole thing? No, it's impossible. here. So let's say you displace this. What about these places here? So CSF is found everywhere. You can't displace all of them. It's impossible, right? Or blood is scattered everywhere. Every tissue here has blood, has capillaries. So it's impossible to displace blood or CSF completely. So therefore, what's the closest again to the opening? The brain stem. So there's only one opening, which is at the base of the skull. So what this is telling us really, there will be brain herniation. And once brain herniation occurs, your patient's screwed, right? Because now because the opening of the foramen magnum, is it the same size as the brain stem? So now what will happen if you squeeze a soft, squishy tissue through a small opening? It's gonna strangulate it, right? So what will happen to all that tissues now? Necrotic die. Then of course the patient will die first before any of these will occur. Correct. So all the primitive functions of your brain is in that brainstem. Okay, basic functions like breathing, heart rate, blood pressure. The reticular activating system is there. So therefore the center of consciousness is there. So therefore, if that's squished, what happens to your level of consciousness? Drops. So that's when your Glasgow Coma scale score will be 8 or less. Okay, you can go down even as low as 3. So we have different layers. So scalp injury is still head injury. Okay, now the scalp can be very bloody. So don't get scared when your patients fall, for instance, and you see a pool of blood. Doesn't really mean their skull cracked. Okay, the skull could be intact, but because our scalp is very vascular, you hit it, it will bleed a lot. So don't get scared right away. Okay, you may scare, oh my God, baby is dead. No, it's just probably the scalp. Okay, so it just busted a really big vessel. So here, the scalp bleeds profusely when injured. And it can look scary. You may think, oh, this patient's gone. Okay? No, they're not. It's just the scalp, all right? Yeah. So these are the possible injuries you'll have. Again, these are just the primary injury. Okay, so we still have those 6 secondary injuries to worry about. Fractures can be open or closed. With an open skull fracture, then that means the Monroe-Kelly doctrine does not apply. So I can't emphasize enough the importance of wearing a helmet, right? It's very important because let's say you get an accident. You're on a motorcycle, okay, really cool, really big bike, and then you get into an accident. So now if you didn't wear a helmet, that means your brain tissue will be on somebody's tires, on the first responder's shoe, on the barrier. Okay, yeah, it'll be scattered everywhere. At least I'm not saying the helmet will save your life. The point there is we can bury you completely. Okay? All your brain tissue is inside that helmet. No, I'm just kidding. Of course, it saves lives, okay? But that's another reason, right? Hey, we don't have to scrape brain tissue and then... Yeah, that's good. At least all the brain tissue is inside, yeah. You can sew it back on, yeah. The mortician can just glue it back on. All right, manifestations depends on the part of the brain injured. So you may have some focal or non-focal manifestations. Let's talk about a few things. Let's look at the most commonly tested one is the battle sign. So the battle sign is bruising on the mastoid. So either left or right mastoid bone, okay, behind the ear. So if that's present, that means there is what type of fracture? Oh, that's definitely open because yeah, there's hematoma there. So that's a open fracture. Basal skull fractures indicate you have some liquid, clear liquid coming out of your ears or your nose. So that's CSF, and that's dangerous because now that means your meninges are open, so you could be at risk for meningitis, right? Infections because it's open. They inserted the veterans here because they have a high rate of head injuries. Comes with the job. Again, just with stroke or head injury, we all need a CAT scan. That's always the first thing.
Like boxers too.
Right. So it's professional sports, same thing. Now let's discuss this just for a couple minutes. Now, head injury in adults, let me warn you, should you end up in long-term care, now, nobody wants to handle head injuries, okay? Neither the patient nor the nurse, because it's a hassle. Let's say it's okay if it's in the middle of your shift, you have time. But let's say this thing happens, you're clocking out at 7:30. This happens at 6:59. Are you gonna wait for the next shift to handle this? No, this is your problem. Okay. Are you willing to stay over? You had plans after. Okay, so therefore, yeah, let's face it, nobody wants a fall, especially if it results in a head injury, okay, at the end of their shift. The problem with this is, remember, there are primary and secondary injuries.
Yeah.
So at the time of the primary injury, so let's say it wasn't an arterial bleed, it was a venous bleed. So therefore the bleeding is trickling, correct? So slowly getting bigger. The hematoma is getting bigger and bigger and bigger. Every hour it's getting bigger. But at the time, a few minutes to several hours, do you see it? No, because the bleeding is so slow. It's okay if it's, I mean, I'm not saying okay, but it actually better if it's arterial because you'll see the manifestations, the injury ahead. Like that. But with venous bleeds, it can be nothing. So let's say the patient and the nurse agreed, okay, you didn't fall, okay? Because the patients, what's in it for the patient? These patients know what's going to happen. They're going to sit in the ER because they don't have any symptoms. Will they get priority in the CAT scan?
No.
No, they'll sit in the ER for who knows how long because the stroke patients, the more symptomatic patients will get first dibs in the MRI and CAT scan. So they'll sit there doing nothing on a stretcher, not even on a bed, because sometimes they won't have beds. Okay, so ER can be packed full. So what will the patient say? Will they go along with the nurse? I got you. Okay,
No.
You take care of me, I'll take care of you. Okay, so the problem there is it can snowball pretty quickly. So once the patient has symptoms, it's probably too late already at that point. All right, so do the right thing. You witnessed the fall, you clearly saw they hit their head. What do? Take care of it. Send the patient to a CAT scan. You didn't see it, and the patient swears to you, I swear, I did not hit my head.
I don't believe it.
Yeah, still do the right thing anyway.
Well, the patient can refuse. You could just document that.
Oh yeah, if they refuse, of course you can document. But at least you did it.
Anticipate.
You washed your hands, okay? Your license is intact. Go straight to the types. Okay, so types of head injury, it'd be contusion. Contusion, you actually have injury to the brain tissue. Now, brain tissue is mostly fat, right?
Yeah.
Fat. So it'll just appear as a dark area on the CAT scan. So it's actually bruising. Okay, so bruised area. The brain, this usually either penetrating trauma or blunt force trauma. Have you heard of coup contra coup, meaning the brain slams against the front of the skull and then ricochets and then hits the back as well? Okay, so that's what we call coup and then contra coup. Okay, so it's basically the brain tissue, let's say usually high impact, let's say car accident. So that's what it is. So it slams against the front of your skull and then slams back again as it'll ricochet and then slam. Right. So you'll have two injuries, one in front and one in the back. So contusion is an example of a coup contra coup injury. Then you have the bleeding. So that may not just be a contusion. This one's an actual bleeding. Of course, any bleeding will result in a hematoma because that blood will clot, correct? When it's outside the vessel. So it'll start with a bleeding first, and then you'll have a hematoma, and you have to evacuate that hematoma. If it's small, you probably leave it alone. But if it's big enough, then it has to be removed surgically. So we'll skip the levels of hematoma because again, it doesn't matter whether it's epidural, subdural, subarachnoid, intracranial, it will occupy space. It will increase intracranial pressure. So here, regardless of different layers, wherever a hematoma is a space occupying lesion, it will cause herniation. Look at the appearance of your ventricles now. They're squished. Okay, can this cause hydrocephalus?
Oh, yeah.
Yes, definitely.
Wow.
So it will increase ICP. Okay, a concussion is a type of mild brain injury. So there's a temporary loss of neurologic function. The loss of consciousness here can be a few seconds or just a moment, up to, let's say, 30 minutes. Okay, so that's a concussion, which is mild brain injury. Now, it's important to know the expected versus unexpected. So what I'm trying to say here is, if it's expected, is it reportable? No. Because the doctor, of course, diagnosed the patient, okay, you have mild traumatic brain injury, which is a concussion. Clear? So the manifestations here are the following. Decrease in level of consciousness, worsening headache. Oh, no, sorry. These are now the reportable ones. Okay, so let's look at the expected first. Let's just say mild, okay? Because this is mild injury, it's not listed here unless there's a table somewhere. No, okay. So the patient may have, let's just cover this one here because that's all that's mentioned in the textbook. Bizarre irrational behavior. So that's depending really on which part of the brain was injured. Okay? Even though this is mild brain injury, it is still brain injury. And remember secondary injuries? Okay, so it may be mild today based on the primary injury. However, once the 6 secondary injuries appear, is it still mild? No more. It's now moderate to even severe TBI. So most concussion patients are not admitted because they do not meet inpatient criteria. The hospital won't get paid. If you admit someone with mild traumatic brain injury, you submit reimbursement. The insurance company will return it. Why'd you admit this patient? For what? Okay, I'm not paying that. However, when you discharge the patient, they must be observed for the following. So this is it now. So if there's any decreasing level of consciousness, worsening headache, so that means, is headache a expected manifestation? Yes, but if it's worsening, no more. So if the patient now has dizziness, seizures, abnormal pupil response, another one here would be nausea, vomiting. Nausea, vomiting, as long as it's not persistent, is expected. However, this one here, you can add persistent or, let's say, violent or severe nausea, vomiting, then that's reportable. Irritability, slurred speech. Is this still head injury? This is now a stroke. Okay, or numbness, that's also a stroke. Definitely, this is all reportable. Now, because they have a headache, what type of intervention will you advise the family or the patient to do? They have a headache.
Don't go to sleep. Take a
Opioids?
medication. No.
Only Tylenol or ibuprofen. Okay, nothing that will alter the right, because if they take an opioid and now they're yeah, I'm good.
I think they're having.
Yeah, it's how can you tell whether is this from the injury or is this from the opioid? Okay, so no opioids. Okay, so nothing that will no sleeping pills either. So nothing that will change the the mental status.
Pupil response abnormal, is that?
Yeah, either let's say asymmetric. So one is responsive, the other not, or let's say it's usually round, right? Our pupils are round. What if it's ovoid now? Have you seen a cat's pupil? Yeah, like that shape. So that's abnormal, clearly. Okay, our pupils are not like that. Our pupils are round. So these are reportable now. So let's say I give you a question on patient was admitted for mild TBI and was discharged home. The nurse will advise the family, the patient and the family members to bring the patient back to the ER when which of the following are observed. Select all and apply. Or I can use a matrix question. Number 49 and 50 on the last exam. And I can put this one under reportable. Second column, expected. And then number 3, 11. We can skip diffuse axonal injury. What this means is, unlike if it's focal injury, meaning it's found in only one section of the brain. If it's diffuse, it's everywhere. Okay.
So we're not gonna.
Yeah, I mean that's for the doctor. I mean, we're not gonna look at a CAT scan or an MRI, right? No, we're not. So you'll just see these described on the notes. So the doctor will say, okay, there are focal injuries or there's a diffuse injury. Treatment of ICP, is it any different from hemorrhagic stroke? Same. So we'll use what drug? Mannitol. Oh, one thing about mannitol. When you draw up mannitol, when you draw up a medication from the vial, from any vial, is there air displacement?
Yeah.
Is it therefore exposed to air?
Yes.
Okay. Mannitol develops microscopic crystals when mixed with air. Okay, so when you draw it up, the mere drawing it up and then it's exposed to the atmosphere, it will develop crystals, microscopic crystals. So therefore, it should be drawn with what? So that those microscopic crystals, a filter needle. Okay, so never draw up mannitol with a regular needle. It should be a filter needle. Okay. You'll see that back home.
Like the glass medication, the ampules.
Well, mannitol comes in either a plastic vial or a glass vial, but usually plastic vial. But anyway, yeah, I remember my first government hospital job. So we didn't have gloves. We had to bring our own. Okay, so we didn't have a lot. Okay, so one time I didn't have gloves, so I was drawing mannitol with my bare hands, and giving them. Administer, and we didn't have IV pumps at that time, so we were pushing them, pushing a 50 ml syringe. I got carpal tunnel syndrome, arthritis early in my life.
It was hard to push.
Yeah, so I had powders in my cuticles, like white powder. That was from the mannitol. And you can tell I didn't wash my hands because I was going home and, oh, you gave mannitol, didn't you? Oh, how did you know? Yeah. At least they didn't mention that you didn't wash your hands. Hey, it's still there. But if somebody said something, I was gonna say, oh, it's very hard to get. It's very hard to remove. So you guys have a lot to thank for. Okay, we can for management of seizures, because these will of course part of this is all under ICP, right?
Yeah.
So we give the levetiracetam, or if you have acute seizures, then they'll be given
Yeah, because then
the razepam or any other sedative. So or you can even give propofol, okay? Or diazepam. We won't discuss brain death because in the first place, we're not the ones declaring the patient brain dead. Okay, so we'll skip it. We can watch, but we don't have a role in it. Does that make sense? Okay. But it's nice to know, right? It would be nice to know if you have. Yeah, so we need an EEG. Okay, so we need actual brain electrical activity. So it can be ascertained when you do an EEG. So this is the same EEG which we do for seizures. Let's say to determine whether the patient had a seizure.
that's how we yeah, right.
But the important thing here is for OPO, for organ procurement, because once somebody is declared brain dead, your next action is to call OPO, okay, organ procurement. Okay, so they'll come. You don't have to do anything. Just call them and they'll take care of it. You don't have to talk to the family. Okay, they'll be the ones to talk to the family.
So, Professor, even if the organs aren't viable, still need to call them?
Yeah, it's just protocol. They have
If somebody
well, you can't really tell whether it's viable or not. They have their evaluation criteria, and yeah, they can harvest stuff out of brain dead patients.
the eyes.
Okay, we did this already, and your masters, right?
Oh yeah.
I remember you cannot bring this to the test.
Which test now?
Mine and the NCLEX. So none.
That's just like
I agree with
No.
They giving us a lot.
years of running
And no. Let's see what happens.
by heart.
I can tell you if it's going on.
Okay. One ominous sign. So most of these patients, especially if it's moderate to severe traumatic brain injury, they do not survive. The most you can keep them alive, the brain alive, will probably be 48 hours. That's it. And then they'll be either dead or brain dead. Okay. So for, again, severe traumatic brain injuries, almost all of them will die. You can keep them alive, that way you can buy time, families can say goodbye, stuff like that. So the ominous sign will be the following. We call it Cushing's reflex, or also called Cushing's triad. What are they? Now, different authors have some variations though, but this textbook says the triad are bradycardia, increasing systolic blood pressure with a wide pulse pressure. So that's 3, correct? Okay. However, I don't know which book the NCLEX will use, because other authors say bradycardia. Number 2 is both of these is 1, meaning they'll say increasing systolic blood pressure with wide pulse pressure. And then the third is Cheyne-Stokes respirations. Cheyne-Stokes respirations. No, the abnormal breathing, like this.
Yes.
All right. So again, I don't know which reference the NCLEX will use. So, however, on the test question, will it say bradycardia, or will it show a low heart rate? Will it say increased systolic blood pressure or an actual blood pressure? What is pulse pressure?
Between,
Difference of
systolic and.
Between the systolic and diastolic pressure. So show me an example of an increasing systolic blood pressure with wide pulse pressure.
180 over. 180 over 7.
That's
Yeah.
very wide, but yes, okay, that's extremely wide. Because the normal pulse pressure is what?
40.
40, correct? Okay, so this one, that means the patient is
Very
gonna die. Okay, so when you see Cushing's triad, because this is proof of severe increased ICP. So severe increases in ICP results in Cushing's triad. So this confirms the patient has really high ICP. Bad news is they're gonna be brain dead pretty soon. Again, SIADH, diabetes insipidus. I won't repeat that. Watch them for either complication. Sometimes we're so busy saving the patient's life and we forget to feed them. So make sure the doctor's aware that we have a feeding tube, okay? Because sometimes, again, we can't forget, okay? It's easy. Yeah, happened to me one time. A septic shock patient. 3 a.m. lab called. Hey, your blood sugar, your patient blood sugar is 5, and she's been unconscious the whole shift. And then I said to my charge nurse, "Oh, no wonder she's unconscious, huh?" Yeah. But we were busy. I was doing the dopamine. Patients on the dopamine drip. So that's every 5 minutes, titrate. I lived there in the cubicle. I couldn't leave that room because she was full code.
We should have some people here.
Huh?
We should have some people here.
Well, that patient's the only reason she was still full code was, oh yeah, and alive was because her husband couldn't let her go. Yeah, I mean, he wasn't there 24/7, but he didn't sign a DNR, you know, so we were doing aggressive stuff, but there was no way the patient was gonna survive. Of course she died. The next day, yeah, so he came to, you know, probably hit the acceptance stage of grieving, and then, you know, he said goodbye, and she was awake, you know, at that moment, and then they said goodbyes, and then he signed it, and then she was dead shortly, you know, after. Yeah. They only had each other. Okay? They had like estranged kids or something like that. The kids were not around. Okay, we'll stop here.
Yeah, we can go.